My name is Val Soul. I'm here as a representative of Philadelphia Fight, as well as ACT UP Philadelphia, the AIDS Coalition to Unleash Power. And I am here, this panel is what about the unique needs of transgender populations when talking about prevention services. Unfortunately, one of our panelists couldn't join us today. She's actually double booked at this very workshop time period. So we had a last minute frantic conversation and she's with another workshop. So I want to introduce her and tell you a little bit about the work that she does because it's an important piece of trans services in the city. Her name is Andrea Lenore Harrington, and she works with the Morris Home, which is Philadelphia and pretty much the world's first ever transgender-specific drug and alcohol residential treatment program. So in Southwest Philadelphia, they have 8 beds for people of trans people of many types of trans population. It's not just female to male or male to female. Anybody who is trans identified and seeking help stopping drug use is welcome to get a spot at the Morris Home. So if you want more information about that, at the end, come see me. So I work at Philadelphia Fight. I'm a trans-identified person. I use the pronouns she, and I identify as trans and as a woman. And so I'm really pleased to be here with this esteemed panel of people doing really, really amazing, awesome work in the city about prevention for trans folks. So I'm going to briefly tell you their names, and then they'll give you a little bit, introduce themselves a little bit. I should say before we start, this is not a Trans 101 session. We are not going to be getting into individual people's decisions about their bodies or their presentation in the world. If you feel like that's individual people's decisions about their bodies or their presentation in the world, we welcome questions about what. We're not doing a Trans 101. We're really doing a specific, kind of a surgical focus on the prevention-specific needs of trans-specific populations. Can I use the word specific anymore in that sentence? I don't think so. Joining us here are Key Alexander, who will tell you more about himself, Trista Gaucher, and, I'm sorry, I'm so Gaucher, and Lee Carson. When we were setting up this panel, we really wanted to identify some of the different types of populations that we're talking about when we talk about trans populations, because all trans populations do not look the same. So I'm going to start a short list for us on this easel board, and I have to move it over, and there's markers somewhere on the bottom there. So I'm going to start a short list, and then when the panelists introduce themselves, I'm going to ask them to tell us about themselves and about the work that they do, but then also add terms to the board that we're going to put together, because there's no way that one list will even accurately represent all of the different ways that people can be trans. So I'm going to start that with the words transgender, transsexual, gender fluid, and intersex, and then we can add more onto those. Maybe while I'm doing that, our panelists can start introducing themselves.
I'm sorry, what question am I answering?
Who are you? What work do you do?
Oh, okay,
and
sorry.
What words would you add to the board besides the 4 that I said?
Hi, everybody. I'm Trista Gaucher. I am the case manager and counselor at the Trans Health Information Project. We are a peer-led multi-service organization. We are a peer Philadelphia area for people who are trans and or gender variant identified. We offer case management, counseling, advocacy, and education to our communities, as well as people outside the communities. Like if an agency would need a trans presentation, we can offer that. And what other things would I add to that? Well, gender queer. Some people make a distinction between gender fluidity and gender queerness. a lot of terms, actually. Bi-gendered, two-spirited, multi-gendered. Go ahead.
So hello everyone. My name is Key Alexander and I work for the Zoning Center, which is an LGBT Health and Wellness Center based in Philadelphia. We have a whole gamut of health services. We kind of do health and wellness. We have a health clinic at 809 Lucas, that is like our family clinic, where we do trans-specific care. We have a whole gamut of health services. We kind of do referrals. We have a health clinic at 809 Lucas. Body wellness. And then we also have our offices on 12th and Chestnut, where we have HIV case management for folks who are HIV positive. We have a food bank, we have housing referrals, we have behavioral health, and we also I'm part of the education team, and I am a community health educator, so I do mostly sexuality education within the school system and community-based settings all over Philadelphia. I also run the Young Trans and Unified, which is a support group for trans and gender youth ages 14 to 23 at the Attic Youth Center. So we meet weekly and it's basically a space for young folks to be able to talk about their trans experience and get support. And I'm probably at gender varying, as well as gender non-conforming.
Can you guys just speak a little bit more into it?
Okay. All right. My name is Lee Carson, and I work full-time as a behavioral science researcher for Public Health Management Corporation, which is located at Broad and Spruce here in Center City, and I've been there about 7.5 years. We're also projects I work on Broad and Spruce. This time to stay up, but initially we're HIV prevention among MSM, and more recently we've gotten into sort of health needs of Black men in general, and I also worked on a needs assessment in collaboration with transgender communities that was released, I think, around 2008. And there are a few people in the room who helped out with that. And then I also worked part-time for about 6 years for the Zoning Center as a mental health therapist. I can't believe it's been that long, actually, a little over 6 years. And then I also teach as an adjunct instructor at Temple University in the social work department. So I typically teach master's level students. And one of the things when we get into, because there's a part of the course that I teach, that I'll be teaching again this semester, that sort of talks about LGBT communities, with the plural obviously. And so I actually had Key and I had Andrea come in because I would quite honestly prefer to spend more time with them talking on trans issues and gender variance issues along those lines, because I think that people hear a lot about LGB stuff, or at least LG stuff, I'll say that. And so I think it's really important that as social workers that they also understand the complexities of gender. And I think that that's something that a lot of students, and Key maybe can attest because he does come and talk to my students, that some folks have a lot of difficulty wrapping their heads around. And there are a few other things I do. I'm also the co-chair of the City LGBT Democratic Club, which is completely volunteer for me. So there are a few other things that I do, but for the purpose of today, most of my comments will be coming from the research side as well as my work as a therapist.
Lee, do you have any terms?
As far as terms, I would say no. Like, that looks pretty comprehensive to me. So that's the benefit of going last. I don't have to try to add to that list. So no, I think that's pretty good.
Okay. So, as you can tell, there are a lot of different populations represented on the board, and we could get more specific if we wanted to. But today's presentation, what I really want to ask the panelists about, and what I'm interested in also hearing from the audience about, is the specific prevention needs that trans people have. Any on that list, or not? I really want to ask the list that fundamentally is different from or unique from the type of prevention messages or prevention language or prevention materials that already exist. What have we already done in the city to address some of those gaps? And what are things that we need to be looking at to get at the gaps that are left by language or prevention materials that aren't often trans-specific? As a person who's done prevention and treatment education at Philadelphia Fight since 2000, I've often seen that if somebody doesn't think that material is about them or really for them, it might be useful for them, but they're not hearing it. So how can we really target our prevention messages better? So the first question for the panel is, what are some of the national level barriers? Barriers that are bigger than just Philadelphia that get in the way of doing adequate prevention messaging for trans populations. So some of the things as we were planning this that we might talk about. When I mean national level barriers, I mean anything from the fact that the CDC doesn't have trans-specific interventions to the fact that the CDC lists trans women as men who have sex with men, right? So those sort of structural things all the way down to the cultural or societal stigmas around trans identity. So I'm going to stop answering the questions, just leading the panelists. Can I rearrange this so that I scoot you over a little bit and put my check there? So any of you feel moved to start first?
I guess I will. So I think we talk about language a lot, especially, the CDC does, consider trans women to be under an MSM population, which is really problematic. It's also just really hard, especially when testing forms that are made by the CDC, it's also just really hard, especially with inclusion. If I'm a transgender man and I'm having sex with other transgender men, there's no room on that form to report what's going on. So it's like also, if people are in non-monogamous relationships and they're like, well, I have a partner who may be on the MSM umbrella, but then I'm also like sleeping with a trans man, or the trans man I'm sleeping with other sorts of MS, like, cisgendered men, like what does that mean? So it's really hard when we're talking about collecting data even because, there's no really specific boxes for trans folks. And I think the other big one is like access to basic needs. Like a lot of, we're trying to get really specific about, the CDC and, prevention, but like most trans folks can't get a job. So like what happens if your basic needs aren't being met? If you don't have anywhere to sleep at night, if you don't have a job, if you don't have any income, things like that. So, people can't afford hormones if they don't have a job. People have to do other forms of high-risk work to be able to survive. So if we're talking about really the national barriers, it trickles down to transphobia and how that perpetuates through all of our society, not just in prevention work. So I think that's a major issue that's at hand.
Okay, so I'll say, I think that what he is saying is absolutely right. We talk about structural level barriers, and that's the real issue because we can no longer afford to look at HIV prevention as just about the sexual acts, right? It really is about the bigger picture, about the context of people's lives. What, are there laws? Like, for example, we're lucky in Philadelphia. And I'm clear that sometimes that though there is an ordinance in the city of Philadelphia that prevents in public accommodations discrimination against LGBT, and that does include gender identity. And so, our mayoral administrations the past few years have been very good with that kind of stuff around LGBT and including gender identity and some of our legislation. That in other parts of the state and nationally, certainly that is not the case. So if we're talking about national level barriers, it's just employment. When things are happening in schools, to me, it's just so depressing and disheartening to hear, like 7-year-old kids who may not fit the gender boxes that people think they should, or the sexual orientation boxes that people think that they should, kill themselves. A 7-year-old kid who hung himself because he was being teased around his sexual orientation, or at least perceived sexual orientation. And so we know that our schools are not really protecting those who are, sort of outside of the sort of heteronormative frame, whether you be LGBT or whatever else. So then if you can't get a good education because you have all this anxiety about what's happening in school and how you're being treated, well, already you have a major barrier. And I don't really understand how teachers are not held more accountable in educational institutions, high schools, things like that, to address these things and to document that they've talked to, whatever X, Y, and Z student about these issues. So I think that's part of it. So and then you get to employment. So there's a number of issues I think that we need to get a handle on if we're even going to think about getting a handle on, the actual HIV prevention needs. And I'm a firm believer, and I'll say this, and I always say this whenever I get to publicly, that, I don't think that that we're going to truly get a handle on the HIV epidemic until we either get a vaccine or biomedical intervention. Now, I'm not saying that it doesn't mean that we should not continue with our behavioral interventions and with our prevention work, because obviously that's needed. But I think that we know that it only takes one time. I can practice safer sex all my life. I have a friend who knows the ins and outs of transmission, and one time slept up and with the wrong person and became HIV positive. So one time, I think there's a lot of issues when we talk about HIV positive issues related to gender identity and transgender communities. I think it becomes even more complex. So
I just want to talk about the barriers and. For example, the CDC reporting trans women as MSM for the way that trans populations are marketed to and with prevention strategies can actually further exacerbate the very things that we're trying to prevent. Because when you market to a woman and you lump her into a category of men who have sex with men, you're making an assumption about her sexuality. But you're also, of course, making an assumption about her gender identity, and that dehumanizes people. And that affects their self-esteem. And when you affect their self-esteem, they start making poor choices, start making unhealthy choices. So actually, the CDC is doing things that are counterproductive to their supposed goals. So, that's something that, we're talking about these national barriers and how they affect our work. I like to approach people in ways and kind of try to, mitigate those things that I know. That's something that we're talking about these national barriers and how they affect our work.
As someone who teaches sexuality education, our sexuality education is so heteronormative, in the fact that we're only talking about people who are born male and identify as male, who are sleeping with women who were born women and identify as women. And it's when young people don't know how to talk about their bodies, they're not able to make these informed decisions, right? So they can't protect themselves if they don't know what the options are. Because, a trans woman might need to be protected another way, and we shoot this thing of condom use to MSM, but all trans women have a different interaction with her body. So to be able to say, well, I can do this thing, just like they told me with all the rest of the boys, that's not okay. Trans people have different relationships with their bodies. So we have to be able to, I know that when I do my sexuality education, I'm making sure that I use gender neutral language, that I'm giving options for alternate barriers, because, sometimes condoms and dental dams just aren't going to do it. So how do we talk about other barriers that are safe, that people can use, that are more receptive for their body and make them feel comfortable? So to be able to talk about that, and the school thing, the climate thing is really important. I think we also don't talk about, and this also goes for MSM, we're not talking about people having relationships or why people have low self-esteem and why people are making poor choices about that. We're saying, okay, well, all you gotta do is use a condom, but if I am not dealing with internalized, homophobia or all these things they're doing, I'm just not gonna use a condom, whether you show me how to do it and I can show you how to do it in 5 different ways. So we have to figure out it's deeper than that. It's not just I showed you how to do it so now you can do it.
I want to say one more thing. The budget cuts that we've been facing, I'm sure a lot of you heard ad nauseum about, just makes it so much more difficult to do our work. When we're already short staffed and we don't have an outreach person, and you're forced to cut back, and that affects things, and it's very frustrating. So.
Yeah, I just want to, I'm sorry, one other thing I want to say. This was part of a conversation that we had as we were sort of planning the big conference today. That one of the issues really are that HIV prevention for F to M is almost non-existent. And so I really want to, thank Trista for bringing that up on our call the other day, because that's the thing. And as I was sort of looking up some information in preparation for today, that most of the studies that have been done to look at HIV transmission in trans communities are for male to female trans women. And so there's very few studies, and so there's been, like, for example, there's a meta-analysis done, which basically means that they looked at a whole bunch of studies all together to sort of try to determine what the prevalence of HIV might be among trans women. And trans men weren't factored into there at all. So if I may identify as a gay trans male, which means that that I'm having sex with someone who was born male and identifies as a gay male, my risk, if there's any frontal penetration, is going to be potentially very high if that person says they don't want to use a condom, whatever else. And condom negotiation abilities may vary among people, as we know in general anyway. And so, I think that there's a lot of issues there, but I think that's definitely one major national barrier, particularly for F to M, is that we know virtually nothing about what the prevalence of HIV might be in that population, and sort of what the real risks might be there.
And to go off of that is the other
HIV might be in that
how people
population,
identify
and sort of what the real
We're
risks.
only talking about M to Ms and M to Fs. And to go, we're not talking about people like other variant, people who are two-spirit, people who don't identify with the gender at all. And they also have unique needs. So what happens when all these interventions are geared to very specific things, and people don't choose to have hormones or have surgery or things like that, but they are also not being represented because socially, when we talk about like sex education, they're not being considered. But then when we're talking about these specific interventions, they're also not being considered. So there's a whole gap of trans people or trans experience that is not being targeted at all, and kind of pretend like they don't exist. And so it's really, really hard. There's this specific ideal of what gender queer is or gender variant is, and what happens when people don't fit the boxes that we're giving them.
I'm actually sort of reminded there's a phrase that sometimes comes up, which is same gender loving, which sometimes people use as a term that fits themselves very well, but I always joke that if I were same gender loving, I wouldn't be able to love anybody because nobody else has my gender, right? That like the expansion, I think, of the way that people identify with and relate to gender has really expanded, but our vocabulary, our society, definitely the paperwork has not kept pace. So are there other sort of concrete prevention needs among some of these populations that we can kind of really spell out? I think that we've gotten a good start of some of the concrete needs that people have, but are there other things that you all want to point out, whether it's about lack of access or lack of skills or lack of kind of power in relationships? Are there other examples that you might have?
I think that when we talk about access specifically, I think the thing is that historically trans folks don't gotta go to the doctor, period. So we're not talking about that. We're not talking about that's like a major barrier in itself. It's like if I can't even get to the doctor, there's no way I can talk about my health. And people having access to the things that make them feel good. So if they choose to be on hormones, if they cannot go to the doctor and access hormones, they're going to go get them off the street, which will put them at higher risk, right? And the thing is that in Philadelphia is really lucky. There's so many trans folks in Philadelphia because we do have actually some really great services. And that one of the things is we have informed consent in Philadelphia, which means that if you identify your gender and you want to take hormones, you go to the doctor and they just give you some information. This is what hormones will do to your body. If you can understand that information, you can consent and sign off. In other cities, you can't just do that. You have to have a real life experience, which means you have to live in your preferred gender for at least a year, longer than a year in some cities. which can be really, really dangerous, especially for trans women, because testosterone has such a hard effect on the body that if someone who's a trans woman has already gone through male puberty, they're going to have really rigid features, and they have to live in their preferred gender for a year before they can get access to hormone blockers or estrogen. That can be just really, really dangerous. And so Mazzoni Center does have, we are one of the health centers, and I think that there are some other clinics doing that too, of being able to have informed consent for people to get access to hormones and not have to jump through these hoops to be in their identity. And so that's a huge thing when it comes to access, about like people are starting to go to the doctor because like, oh, I can get my hormones without these like jumps and hoops, oh, I can talk about these things. And the lack of trans competent care. If I go to the emergency room, which has happened to me, I've gone to the emergency room for a gyno emergency because I still have a uterus, and I'm in a bed, and some doctor walks in and was like, you sent me to the wrong room, I thought this was a gyno emergency. I feel shitty then. Like, I'm just like, come on, like, I don't want to have to explain my identity to you when I'm bleeding, and I just want you to fix it. Like, you know, and it's this thing where we don't have people talking about the fact that, like, what happens when a trans person shows up in the emergency room. And so it's really great to have clinics where people can go and say, someone's not going to ask you a million questions about your gender identity. They're going to ask what pronoun you use. They're going to use it, and they're going to give you the care you need to your body without making you feel weird about it.
What's important, I think, for providers to understand is there is a difference between trans friendliness. I know what a trans person is, and trans competency, and having cultural understanding of what different trans and gender population, gendering populations, what their needs are. And can I ask you, if I may, was this at Jefferson?
Yes.
Yeah. I love that. The hospital that's located in the neighborhood isn't really fully understanding of how to deal with the people who fall under the umbrella, you know, the community that they have. You know, it's very unfortunate.
And it's the hospital that's associated with Mazzoni.
And you know, and I will have to say though that I'm actually really proud of Jefferson, because after all these things, I actually had a friend advocate on my behalf and say, hey, this is not okay. And Jefferson then took the initiative to start getting trainings around trans things, right? I haven't heard of any other hospital who's been like, hey, come teach about trans things, right? And yes, they have a long way to go.
I don't want to bash out Jefferson. I had actually a very good,
you know,
Jefferson, where my trans identity was totally respected.
Yeah, so, you know, so it's like,
so it's not all that, but it just
but it's true. It's like interesting. It's like, you know, people are going to take initiative. I think that, you know, because we work closely with Jefferson, they were like, hey, we can't ignore this population if we're working with them closely in this way. They have taken the initiative. I've actually done trainings for the nurses that actually took care of me in the emergency room. You know, things like that. So there are strides being made. But yes, that's like, but it's like one hospital in the city. What happens if I'm in North Philly and something happens and I can't get all the way downtown, you know? So that is really real.
Yeah, I mean, in the study that we worked on, the needs assessment that I worked on a few years ago, I mean, that was when we did some focus groups, as well as, you know, we had a survey, a quantitative survey instrument as well that we administered, but that folks had talked quite a bit about about negative experiences with healthcare providers. And, you know, I think the difficulty is that no matter how much policy we have, for example, we have policy in the city about a non-discrimination ordinance, but how that's actually operationalized is always a very difficult thing. And so, even though it sounds like it always depends no matter where you go, sort of who you happen to get, that there are going to be people who are good on trans issues and gender issues and other people who aren't, but it's good that they really, you know, sort of responded in the way that they did. I'll say that one of the things that I think is really missing is that there are no, when it comes to HIV prevention, is that there are no interventions. So the CDC has a compendium, or what they call effective behavioral interventions. So Debbie's, anyone who probably does direct service work may have heard of the diffusion of effective behavioral interventions. And so there's 30 of them that currently exist on the CDC's website, effectiveinterventions.org. And of those, not one of them is indigenous to transgender communities, meaning that it was developed with transgender communities in mind. There are 2 that have adaptations, which means that they were developed for a different population, like maybe heterosexual women or something like that. For example, SISTA, which is Sisters Informing Sisters on Topics of AIDS. And so they have SISTA T, I think it's called something like that, which is the Jasmine shaking her head, yes, so I guess I got that right. Which is, so they sort of adapted some of the content. And while I don't do sister or sister T, I have to imagine that, unless there was really taken into account, because I think that there's a lot of other issues that heterosexual women don't deal with, that trans women, this is only for trans women, so if you're a trans man, or sort of male identified or along that spectrum, then where do you go? There's absolutely nothing. But again, because, we only have data, because the thing that drives, and I think this was important, I meant to say earlier, that the thing that drives whether or not services get provided at the federal level and funding is by the amount of HIV infections that the government knows about. And so because of the issues around tracking HIV infections in transgender communities, that's why there's so many, I think, issues, and why we don't know much about what's happening with trans men, and why there are, sort of folks who identify more along the masculine spectrum, and why there really are no services for those folks. And so I think that there really needs to be, and TIP actually, I know Amina was really instrumental in putting together Project STAR, which was a project funded by the CDC, indigenously, created by, with trans communities. And, I don't know, I know that Penn was evaluating it, so I don't really know what happened. I don't know if you know anything just about that, but I know that it was being evaluated because in order to make it into the compendium, it has to be what you call like a randomized controlled trial. So it has to be done in a certain way where they can sort of see whether or not the intervention worked versus a placebo kind of thing. And so based on what I saw, Amina, she had come in and had spoken with one of our LGBT advisory board last year sometime. And she was going over all of the content of Project STAR. And I'm like, now this, you can tell, was created indigenously in transgender communities. And so, my real fear is, like there's nothing out there for bisexually active men. There's lots of gaps that exist. And so, I think that, particularly with transgender communities, that's one of the big issues, is that there are no effective behavioral interventions that like TIP can apply for, or Mazzoni can apply for, specifically to really sort of help sort of curb HIV risk with trans communities.
I think it actually gets extra complicated when you put someone's gender on top of their sexuality, because there are there is an intervention, many voices that, has been adapted and trans women are able to go, but then what happens if this is a trans woman who sleeps with women? Or if you have a trans man who sleeps with men, but there's nothing specifically for them. So yes, there's a lot of cracks and gaps in how those work out.
So the mention of Project STAR leads us quite easily into the next question on our agenda, which is, what is the good work that's happening here in the city that gets at some of these gaps? What are the particular programs or organizations, both what's represented here at the table and what's not represented at the table, as well as maybe if there are internet resources that would be good to point out. We mentioned Project STAR. Is there more to say on that? Maybe that's a good starting point.
Well, Amina's my coworker. She's a health educator at TIP, and she runs Project STAR, and she would be able to say a lot more about it. But I think it's again exclusively for trans women, but it's expanded for all trans and gender identifying people. And I think it's just, it's a prevention. It's a group level intervention prevention strategy thing, but she's expanded it to kind of address self-esteem issues, which is logical, right? We address people's self-esteem issues, they make better choices, and then they don't share needles, they don't say sex, things like that. So, but I don't know. That's pretty much what it is, and everybody gets together every week and hangs out and talks about things that are important to them, and Amina facilitates that. As well.
As far as Mazzoni, I did talk about the informed consent that we have in our health clinic. We also have an adolescent youth drop-in on Wednesdays from 5 to 7 at our health center that is for all young people ages 14 to 24 to get any type of services that they need. We do get a lot of trans youth who are going to get hormones prescriptions, things like that, any general care. And then we also have a new program on Fridays from 6 to 9 at Washington West Project, which is our dominant HIV testing site, where we have from 6 to 9, we have basically all LGBT folks who are uninsured can get any type of medical services that they need. And so that's really great. You can just walk up and door, I need this, I need hormones, I need this service, I need to get tested, these things, we do have these things open to the community. And that's something that we're doing to try to break down the barriers to access, because people are like, I don't have insurance, I can't afford to go to the doctor. And we have folks who know about trans identity and can speak to you and respect your gender identity. As far as the group that I run at the Attic, it's really great because it's one, provides a space for trans youth to just be, especially when you're in school and like you're in high school, you're in college, you have to deal with so much other stuff that it's really great to just have a safe space to be and be with your peers and ask questions. We also do a lot of sexual health workshops. It's really great. My co-facilitator is a therapist, so we're able to talk about the mental health thing, and I am a sexual health educator, so we're able to talk about sexual health in a very specific way, specific to their bodies, specific to their experience, which is really, really helpful. And we've been able to, help them answer questions and make better decisions in those ways. Those are the best kind of prevention methods that I see that are happening as far as the programs I have applied.
Not doing a lot of direct service other than working as a therapist. I don't know a lot on that end, but one of the things I think that's good is on the data collection end. That at PHMC we have what we call like a household health survey that we administer to a few thousand people in the southeastern Pennsylvania area, and for a couple of those years, and so it happens every 2 years, that we've included a gender identity question in there. For at least a couple of those periods, so that it did allow us to be able to, and even though there were very small numbers of folks that they were able to identify based on the gender identity questions that we asked, it still gave us a little bit of data to be able to look at. The needs assessment that we worked on at PHMC a few years ago. So I think that one of the positive things, in addition to what Trista and Key were saying, is that there are lots of good services here in Philadelphia, I think, and we're collecting some information to really kind of help better understand some of the needs. And one of the things that I'm hoping at PHMC at some point is that we will be able to get a larger study funded where we're able to do a more comprehensive job. Because that needs assessment that we did was like $15,000, which isn't a lot of money at all when you talk about a research study trying to really get at the more nuanced, complex needs of transgender populations. And so I'm hoping that at some point us, or even whether it's Penn or Temple or someone, really gets a larger funding stream to be able to really do some comprehensive work around documenting and understanding the needs of transgender populations, because research oftentimes is what really can help to drive funding. And so if we better understand those needs, then I think we'll be able to better develop interventions and things like that and advocate. Because it's much easier to advocate with the legislator or city council person and mayor. It's much easier to advocate with the legislator, ex-council person. We documented X, Y, Z in this study. That will make them listen. So I think that's where we really need to be able to go, for the future, as far as really trying to document the needs and sort of move things forward.
Yeah, it's funny because data and evaluation is so key to the increases in funding and making a solid argument for why your thing deserves to be funded. So a lot of times you end up having to do work that's unfunded so that you can prove that the work works so that then you can get funded, which is like a boondoggle if I've ever heard one. I want to represent for a couple of minutes the work of Morris Home. I mentioned it at the beginning. It's the only trans-specific residential recovery treatment program, and part of the reason why that's considered as prevention work is that we take a very broad lens onto what's prevention. And Key had sort of alluded to this, but if somebody doesn't have stable housing, then their decisions around who they go home with or where they go at night are very different from the decisions of somebody who has stable housing or housing that they feel safe in. So in a similar way, you know, it's a residential program, but people who are in substance use situation in a matter of chaotic use, as in they're sort of chasing the next hit, as opposed to kind of being able to think about long-term planning. That their prevention decisions are very different. They're seen through a very different lens than people who are not in chaotic drug use. Maybe people who are in regular use or recreational use, but not in the sort of like complete life of people of chaotic drug use. So helping people stabilize and set some footsteps down the road towards recovery definitely helps people to, like Trista's saying, kind of gain some self-esteem and start to make different decisions for themselves. One of the things Jane Scholl always says is, and this only kind of applies here, but the principle is true, is if you want someone to put on a condom, give them a future, right? That people don't take risks unless the benefit that they see of taking that risk is greater than what they perceive the risk to be. So someone who doesn't really believe that they are worth keeping safe, or someone who believes that, as we were kind of talking about on the call, that HIV infection is inevitable in trans populations, so why not just do this thing, because I'm going to get it anyways, that's what the data says. You know, the sort of like misreading of the data. So I just want to represent Morris Home as not just a treatment program, but as a piece of HIV prevention. And that is open to people regardless of HIV status, whether positive or not. At FIGHT, we actually have, we don't have any trans-specific programming at FIGHT. However, our Safety Counts program is open to anyone regardless of HIV status who is using, and it's actually led by someone who has, over the past year, worked very hard to make it a trans-accepting space. And she's someone whose gender identity, well, I don't want to speak for her, but her gender identity is not cisgender, heterosexual. She's definitely someone who has a broader sense of her own identity, gender identity. And so she works very hard to make it a safe space for trans people who may come in, even though it's not trans-only space. And that's open to anybody who's actively using drugs. It's a harm reduction program, so people sort of look at their own use, look at their own behaviors, and not change everything, but change a piece. Pick a thing that might be leading them to have exposures or have some increased risk, and change just one piece, just a small goal. I also don't want to be too premature, but we have applied for a large grant that would be a collaboration with CHOP that would be particularly retention and care for HIV positive people of a broad gender spectrum. So it's sort of we're interpreting it more broadly than the grant is actually written, which we kind of have to do in order to make it meet our standards of what it should be and not just what the grant says it should be. So we sort of mentioned the complicated, nuanced needs of trans populations, and I was hoping that the panelists could share some reflections on intersections of racism, sexism, homophobia, and transphobia. There might be other isms that you want to throw in the mix, but just sort of an intersectional analysis of why prevention needs might not be getting met among trans folks.
So I'd like to invite you to a separate session that's going to be 3 hours long to talk about this. It's a really, I can go on forever to talk about this, but it's a really complicated thing. I think especially when you think about violence towards LGBT people, 40% of hate crimes that are enacted against LGBT people are 40% on trans women of color specifically. And it's this thing where brown trans folks are disproportionately being marginalized and targeted around their gender, especially, and I always like to think about the way that masculinity plays out in this, because the thing is that trans women who are going to have their gender be disrespected are considered to be some dude in a dress. But then they're still seen as a black man, and then we have our own societal issues about what we think black men do, right? And so because we have our own gripes with that, and we're disrespecting trans women's identity, they get lumped into that, right? And then that's perpetuated by the CDC, by interventions, things like that. So it becomes this really much bigger thing than just a simple, like, I don't want this trans person there. It was much deeper than that. And I think the other thing is, when we're talking about brown folks don't go to the doctor, right? So if you're brown and trans, you really don't go to the doctor, right? And so what are the things that we're doing that are culturally competent to be able to reach folks in this way? And I think that there are a lot of things going specifically towards trans women of color because there's so much focus on black and brown MSM work, right? And so trans women get lumped into that, but then what happens to brown trans men, or people who are gender variant and don't fit either boxes who happen to also be of color? And folks of color disproportionately suffer from, lack of housing or drug use or things like that. When you're having to deal with constant isms in your life, you're not going to be able to make the healthiest decisions. So how do we talk about those intersections when we're talking about things that are culturally competent to be able to say, I understand that because you have a different experience, you're going to have different needs and different wants. How do we do that on top of the trans thing? I don't think we figured out the trans thing yet, so we still got ways to go with that. That's my one piece.
Yeah, it is a very complicated, it could be its own workshop. I mean, I don't know. It's like, most of my clients are trans women, and most of those are African American. And, I hear a lot, and then there is a propensity, but not necessarily, for those women to do sex work because of the discrimination involved that trans people face. And usually it's trans women because, as you mentioned earlier, if you've gone through testosterone puberty, fueled puberty, you're going to have masculizing characteristics, which is going to mean that you're going to be read as a dude in a dress, right? And trans men have the benefit of going the other way. You can sort of pass under the radar, and I'm using other people's terms in that way. But what I hear is there's a lot of racial profiling, of course, right? And then if you're trans, if you're being read as trans, there's going to be gender profiling or gender policing, right? So you're going to be targeted. It seems to me like a lot of black trans women are assumed to be sex workers. And so they're targeted and they're incarcerated. And they may not be doing anything, but cops make it happen so that they can get incarcerated. So that's like a problem. And it's difficult to address, Another intersection is homophobia, and that is, I see, there's a lot of people trying to appropriate people's sexualities because it's the whole MSM thing. Trans women is MSM, like to make it convenient for everyone because no one wants to really understand what it means to be transgender. That it's easier for them to process a trans woman as a man who has sex with men, assuming she has sex with men. And so there's that, it's weird. It's like a transphobia, and then once they're lumped as MSM, then there's going to be some homophobia, and then if you're African American, then there's going to be racism, and then there's just layers and layers of stuff that people have to overcome. No wonder you got people, making poor choices because they're being treated so poorly, right? So I don't have a solution for any of this other than my approach with my clients is to address everybody like individuals. I don't like to personally assume that every trans person, if they're a trans woman, a trans man, gender variant, whatever, I don't like to assume that they all have the same needs just because they're a trans woman, just like I wouldn't with any other woman or man. So that's my particular prevention strategy and all that kind of stuff.
So I sort of love, so one of the theoretical frameworks I absolutely love and I talk to my students about all the time now is intersectionality. So you sort of use the word intersections, but there's actually a whole theoretical framework called intersectionality. And so essentially what that's, and it comes out actually of the feminist movement where, and back in the, 40s, 50s, 60s that, you know, women were like, oh, we're all the same. And then the black women were like, oh, girlfriend, no. Because you still have a little bit more privilege than I do. And so intersectionality really began to emerge out of the feminist movement and has sort of spread into other areas, which essentially says that, you know, we all, I sometimes will say multiple identities, but then people start thinking they got multiple personality disorder or something. But often when you read about it, it talks about identities, but we all have multiple intersections. I'm black, I'm gay, I'm a male, I'm a brother, you know, so we all of us have multiple intersections in our lives of who we are, whether it's about ability, whether or not I can walk freely, or whether or not I'm in a wheelchair. All of these things impact how people see us, how we interact in the world. And we can't, you know, I can't walk into a space and remove my blackness. I can't walk into a space and remove my maleness necessarily, or whatever else. And so that sort of intersectionality sort of talks about that, you know, all of these multiple intersections are intertwined, they're not additive, we can't just take them away. And so in my practice, I agree with you 100%. And what I try to sort of engage in my therapy work, and what I talk to my social work students about, is that, you know, everybody, you know, based on our social interactions in the world, in our environment, in our families, that we construct our identities differently, or how we feel about our identities differently. So every black person, we cannot look at black people, all black men, even the same two people in the same family, the same way. It's impossible, or it's not impossible to do, but if you do, then you're doing a disservice to that person. And so I really try to encourage people to look at, you have to understand the person's experience. Yes, there are some things that historically or whatever else that people may have experienced. And so, I say to my clients, I'm not completely green. It's not that I don't know anything. But what I want to do is I want to understand your experience and how your experiences have shaped who you are today and the problems that you may be while you're coming to counseling for. And so I think that looking at those various intersections is really important of a person's identity, because some of those are privileged identities and some of them are oppressed identities or marginalized identities, whichever word you prefer to use. And so some people have issues with certain, may have some issues with certain parts of their intersections. Obviously because of, you know, what their interactions are with society, how they're treated as a trans man, as a trans woman, as a gender variant person, as a black person, as a, you know, it can go on and on and on and on and on. And so I do think that it becomes difficult, and in my work, because we are never, you know, going to completely eradicate racism. We are never going to completely eradicate homophobia, transphobia. Yes, we should always do our part to eradicate that and to lessen it. But I think we need to realize that shit is here to stay. But what we do, my work, I'd rather strengthen the person. That if we can really strengthen the individual to be able to deal with those external assaults that are going to come likely, then I think that that's the work that I see myself doing. Yes, I will still work on the structural levels. I will still work to address community level stuff. But I do think that our work really should be trying to strengthen the individual, because if you strengthen the individual, not only are you helping them deal more effectively with those external assaults, but also maybe improving their self-esteem and, you know, making more of a dent on HIV prevention work and things like that. And so, you know, I think it is important for us to really respect and to understand what the intersections are of the person that's in front of us, and how we honor that, and how we really sort of help to strengthen people in those areas where, you know, where they may not feel so strong. And that's really, you know, what I talk with my students about, probably the last couple of years, I've learned more about intersectionality as a framework, and have really been trying to implement that in my own life, in my own practice. And so I really sort of push that big time. So I do think that that is an area for us to look at. And in our interventions, they just don't. I mean, you know, we have an individual level intervention that I'm working on here. It's for bisexually active black men. So there's nothing in the country that exists like that. And so the benefit of individual level interventions is that you can get to those nuanced levels that you can't get to in a group level intervention necessarily, and certainly the community level intervention you can't address. However, individual level interventions are the most expensive form of intervention. They reach the least amount of people. However, I feel that they are better at making qualitative changes in people's lives that can't necessarily be done in a community level. Okay, testing makes me stronger. You know what I'm saying? Like, okay, so maybe I'll go and test, but what about all this other stuff that I'm dealing with in my life that just by simply testing for HIV is not going to change? And so my hope is that, that the CDC will continue to fund individual level interventions, that they will develop individual level interventions for populations that are at risk that don't have any now, and there are very few ILIs out there. But again, I think it's about, really if we're going to make a dent on things, not only the biomedical stuff that we, like the microbicides and vaccines and things like that we need, but also how do we qualitatively improve people's lives. And that's, I think, where we struggle in HIV prevention work, because we're not really funded, most organizations I don't think are really funded to be able to make those kind of qualitative changes to people's lives that are needed.
Just another thing about, I think that having that framework is really, really important, especially with medical providers. I think because, when you're saying the thing coming from the feminist movement, like a Black woman, her experience as a woman will always be racialized, and her experience as a Black person will always be sexualized. So like, how does a medical provider address these social issues that come with that? And then talking about, when people are talking about gender and how people move through the world, I was at a workshop once where, a white trans woman was saying, trans men have it so easy all the time, bam. And a trans man says, I became a Black man. Like, that's a whole other gamut in there, right? So it's like, how do we talk about when people are not talking about, how they have to move through the world differently and how that affects how they take care of their health. So there's that. And then I wanted to bring attention to something that has been in the media of a trans woman from Minnesota named Cece McDonald, who was arrested because she was being targeted by a group of drunk white folks at a bar who were calling her racial slurs and homophobic slurs and transphobic slurs. And they got into a scuffle. Some woman took a shard of glass and cut her across the face. And in defense, she had a pair of scissors because she was a seamstress. She had a pair of scissors in her bag, and she stabbed her attacker, and he ended up dying. She got arrested for murder. And she's been in jail. She's had a lot of coverage. A lot of people in Minnesota have been advocating on her behalf, but then she did plead guilty to second-degree manslaughter, I believe. And then there's this issue of her defending herself because she's a trans woman of color. People are going to think that, of course, she attacked this man on purpose when she was being attacked for being a trans woman of color, essentially. This man had a swastika on his chest, but they didn't bring that into court. So things like that. So she's now she's going to be put in a male facility because she was born male, and so they're going to put her in a male facility. And how does that affect trans people getting their health care? A lot of times people in prison aren't able to get their hormones, right? They're not able to go to the doctor regularly if they have other health things going on. And then we're talking about HIV rates in prisons, things like that. Like, what happens when she's going to get targeted because she's in a male facility and she's a woman, she gets targeted. There's a lot of sexual abuse that happens in the prison system. And that's how HIV rates are getting spread in prison, right? So how do people get protected, not only on the outside but the inside? Sure, this is probably from the prison summit as well. But like, this is also coming down to people's health and how they're talking about how we're protecting people, because it's not just about giving people condoms. It's about talking about their lifestyle and how they would feel the world. So I just felt like it was really important to kind of get into that.
I really appreciate that, Keith. This is the time for audience questions, so please don't hold back. You're holding back. Go in the back of the room, and then I see.
One of the things that, the terminology that you're using, there's such a diversity of being outside of that, it's kind of hard to get a handle. Like, in my head thinking, okay, what does that term mean that they're using? Kind of put it in the context of prevention. I'm just wondering, in the sense of prevention and in the sense of trans folks, the reaction of other people, where can there be education to help to educate people who are not part of that community to be more sensitive to their needs? People who are not necessarily medical people, just people generally in the community who are going to have an impact on a transgender person's self-esteem or interactions. I mean, sometimes people, there's just like, from my perspective, I'm totally open for diversity, but I don't understand the terminology to know what it is.
Well, I answer that. Twofold. One, I think as providers, we have a responsibility to understand the population we serve, and we have to take initiative to educate ourselves. And we can do that on our own. Internet, great resource. Another one is ask your clients, hey, what does two-spirited mean to you? What does it mean when you say you're gender fluid? I'd like to know. And see, the thing is that's how we're going to make our clients realize that we care about them. And when we care about them, they're going to start to care about themselves. And then they're going to make better choices about their lives. And that's the most important prevention work, if you ask me. It's not just understanding all the right words and stuff. It's, you know what I mean, really care about the individual. Whether they're trans or not, or whatever ethnicity they are, their religion or whatever, is you have to really care about the person you're helping.
And I think when you're sharing community with folks, asking is really the biggest thing. I think this other thing is like knowing how to ask, because there's a difference between saying, hey, what does two-spirit mean to you, and what's in your pants? Right? Those are two very, very different questions. Some people are like, well, I'm just trying to understand your trans identity, so what's between your legs? Like, that has really nothing to do with it. I tell young people when we talk about trans things, I was like, think about the question you're about to ask, and if you don't feel comfortable asking it, or answering it, don't ask it, right? So people are like, no, I'm not gonna, you don't walk up to any woman on the street and be like, so how's your vagina doing? Like, no, like, that's just not okay, right? So like, we don't have the right to ask trans people about their bodies, but we do have the right to learn. And so if you're saying, hey, like, and the other thing is knowing that not all trans people want to be educators. Like, you know, I'm up here because I'm an educator, and I happen to be trans. So if you ask me something about trans things, I'll tell you, right? But not everybody's going to be in that role. So also respecting people's decision to say, actually, I don't really feel comfortable talking about that, but here are some resources. Or if you say, hey, if you don't want to talk to me, do you know where I can go to find things? Because the other thing is there are people in trans community who don't know half those words up there, right? So it's not necessarily about knowing the lingo, it's about being sure that you're asking questions and you're knowing how to ask them.
And the only other thing I add is that, you know, I think another great place is a gold mine that we have here, lucky to have in the city, is a Trans Health Conference. And so it's completely free, happens here in this building annually, and, you know, to just come and to meet people and go to the Trans 101, you know, sort of sessions and things like that. But, I mean, that happens every year here in Philadelphia, where people all over the world really come here for that. So I definitely would suggest that as something to go to once a year, but in addition to the other things that we just talked about.
The Trans Health Conference is free. Everybody loves free.
And it's 3 days long.
Yeah, free.
So go ahead.
Well, I was going to offer myself up, if I may. I work for the Department of Behavioral Health, and I've been working there since January now, and I coordinate the LGBTQI initiative. Part of my role is actually going to providers and actually talking about this. So I would love to put myself out there as someone to come to wherever you are to talk to you about this, because this is really important to me and it's really important to the city, which is great to know that I'm a part of that, that this is an initiative and it's trying to be really pushed out there to everyone in the city that's providing services to these communities. So please, I would love to talk to you about that. And, you know, it's not just me coming, it's bringing on board people who are doing similar work. So I would love to talk to you about that. But I also wanted to say that I love about making the medical industry accountable, because the American Med Student Association came to Widener, where I go to school, and they said, what association came to Widener, where I go to school, and we don't get it in med school. There's only a handful of schools that actually get that. So I know that there are students that are thirsting for that knowledge. So I'd love to hear it with anyone that's doing that, that's like, okay, hey, let me come and talk to you about this, because this is truly important. And they really do want that, so.
I've gone to Temple and see this.
Yeah, it's
a
amazing.
presentation on what a trans person is.
Yeah.
It's a little old, but, you know, that's really an important population to intervene is medical students.
Yeah.
Because they're going to become the doctors, and they're the ones who are making decisions about, you know, how people are going to be cared for, and that's huge.
We also
It's a prevention thing, I mean, really.
We also, yeah, I think that we actually just got a grant so that we can have someone specifically working with medical providers. So that is something that we're looking forward to doing.
And I know that Temple University, there were 2 students at Temple University, and I can't remember the names, that was a couple of years ago, that they had developed a curriculum, and I don't know how trans inclusive it was, but I know, I believe it was to sort of educate medical students about LGBT issues, because as you were saying, that human sexuality often isn't really covered in the context of, I guess, when folks are being trained as doctors, and so they had a curriculum that they had developed. They were really trying to train doctors, at least locally, so, or maybe even just at Temple, I don't know. But it's good that you guys, because obviously with Dr. Wynn there and you guys are a medical facility, that there's a lot that you guys have to offer to that as well as TIP does. So.
Well, and I definitely have people to send your way because we do presentations about HIV treatment and prevention in recovery house settings all across the city, and we often get requests from those providers to do LGBT trainings, and I want to send them your way.
I was just going to say, part of the Trans Health Conference that was new this past year, and is going to hopefully be continued and possibly move outside the conference to other offerings, is something called the Trans Medicine Education Initiative, which is, instead of, before it was just a provider day and 8 provider workshops, is now a 3-day intensive workshop segment just for providers, and it's specifically geared towards medical education and cultural competency, and even getting into a little bit more advanced medical things, but what you can see it on a community level, right, which is really cool thing.
Yeah, so as opposed to kind of 3 hours that you might get in a workshop, it is 18 or 20 hours worth of training. So.
Which is still not enough.
Right. Other questions?
Yeah, you mentioned something about the Morgan House. Can you explain that a little bit? I wouldn't understand the Morgan House.
So the Morris Home is run by RHD, Resources for Human Development, and it is an 8-bed facility in Southwest Philly that is welcoming trans individuals to do residential recovery treatment. So it's I think the max length of stay is probably 9 months, but they just opened, they've already had some turnover, so they're definitely looking for referrals. Anybody who's trans identified can get placed there if they're seeking recovery
I heard
treatment.
the Wilson was longer. I heard that they wanted to keep it the 1 to 2 years.
That's
Like,
badass.
yeah.
I think the other great thing about that people don't realize is that a lot of recovery homes, shelters, and things like that are gendered. So if you have trans people going in there, and you're a trans woman, and then they have to go to a male shelter, a male treatment facility, and they're just not being respected, and amongst the residents, amongst staff, things like that. So that's the other reason why Morris Home is really powerful, because it's trans affirming in that way that like you don't have to deal with that crap. You can just like be amongst people who understand right.
But in 2006, I'm sorry.
I was just going to say, I hear constantly my clients, like, they're homeless, I send them to a shelter, and, you know, a trans woman goes to the female shelter and is told, no, you got to go with the guys. She feels completely unsafe, disrespected, like, invisible, you know, and it goes with the guys, and then, you know, I've had physical assaults and things like that happen, and what's she going to do? She's going to pick the street instead. And then maybe she'll end up doing a little sex work, and then doing a little shooting up, you know, or whatever.
In 2006, when gender identity was added to the fair use charter of the city, there was actually a grant to do trainings at all of the city's shelters, both the intake centers and the sort of like places where OSH places individuals in housing situations, because the way that the fair use charter is interpreted is that reasonable accommodations have to be made. People have a right to be placed in a facility where they feel comfortable as they are currently presenting. Not like as some figurehead says, like, oh, I will police your gender as X or Y, and so therefore here's the place. But as they themselves feel comfortable as they're currently presenting. That was in 2006, right? That was one grant. That grant was never extended. It's not like those people get a training every year and there's plenty of turnover. So all the sites got trained, however many, 6 years ago, right? So it's definitely an ongoing need. It's not like one training in 2006 is going to make it all better, right? Thank you for that. Other questions?
Well, what I love also about Morris Home is something that Trista said is about services being very individualized, and I really appreciate that about these practice guidelines that have been put out now by the Department of Behavioral Health. And I'm not just trying to toot my horn, but I appreciate that, because moving away from this, the consumer, the patient, the that, the other, the whatever, it's the individual person-centered, and it's all modeled on that model. And I think every time I hear, and I've heard you say Morris Home, and I hear it all the time, I'm like, wow, it is so person-centered, and how important that is, and how effective that can be in really, intervening, by having these intervention strategies. So I loved hearing that, and that really sits with me over and over when I talk about, or when I hear about us talk about individuals. And that is really what should resonate, I think, when we walk away. It's like, okay, we're talking about individuals. Yes, we're talking about, a particular group of individuals that identify in a certain way, or a variety of ways. But I love that we're moving toward this, some of us are moving toward this very person-centered intervention, mode of strategic thinking or just strategies.
And I'll say that, and I think that's one of the challenges, and you said it, one of the things you said, the word that was key, is some of us. And so that part of the problem is that even though the Department of Behavioral Health at the top is very supportive of that and is really pushing that, what is happening on the ground is sometimes different. And so how policy gets operationalized and how people become held accountable to that makes all the difference in the world, because you can have policy here, but if it doesn't trickle down to the floor, then it doesn't matter, because what people may know exists and what they're actually experiencing in institutions are two very different things. And what they're going to feel is what they're experiencing the day-to-day, and not what they know to be the case. And those who are empowered enough may be able to say, oh no, you can't treat me that way, but how many people know that? Or if you need the service, you're not going to say anything, because you're going to be kicked out, you're going to be targeted by the staff or whatever else. And so I think somehow you have to get to this place of operationalizing it so that on the ground floor that the consumers of these services are getting patient-centered care, and that unfortunately isn't always the case right now.
Well, thank you, everybody. I see your hand, but we're right over time, so talk to me afterwards, okay? Thank you, everybody, for your time. Thank you for fantastic comments.
Live streaming? Is that what you're doing? No, years later, we're still talking.
We're still live. Thank you everyone for watching the AEM 2012 live stream. We will be streaming other events throughout the month. Stay tuned. Thanks.